When we have a patient who's been diagnosed with atrial fibrillation, and the treatment is very, very much individualized, our main goals are to prevent complications of stroke and heart failure. But the other major goal is to treat symptoms. And some patients have no symptoms, so we then really just focus on the first two. And we can prevent stroke by putting individuals on a blood thinner, and there are several types that have been shown to reduce the risk of stroke. We then also will give medication to control the heart rate if it is not well controlled at baseline. And this includes beta blockers, calcium channel blockers, sometimes digoxin, and some other classes of drugs that can help control the heart rate. Now, in some patients, we may try, because they're having a lot of symptoms or because it might be the first time that they're in atrial fibrillation, we want to try what's called a cardioversion. And this is what you've seen in the ER, where they put pads on and put the patient to sleep briefly and sort of jumpstart or shock the heart back into normal rhythm. This is done particularly in individuals who might have low blood pressure in an emergency situation or who are having a lot of symptoms. For that individual who is having a lot of symptoms, despite us trying to control their heart rate and blood pressure, we need to up the ante a little bit. And so sometimes we'll try the next class of drugs, which we call antiarrhythmics. And there are a number of different medications that are variably effective in keeping people in normal rhythm, normal sinus rhythm. These we start with those that have the least side effects, moving up to those that have more significant side effects. In patients who are older or who do not tolerate the medications or for which the medications have not been effective, we may try more invasive treatments. These include trying to eliminate the source of the atrial fibrillation using a catheter inserted through the leg or the neck that goes and sort of it's called radiofrequency ablation. That's a procedure where we would try to actually burn or cause a small scar at the place that the atrial fibrillation is coming from. This, in properly selected patients, can be very effective. It does not eliminate the need for being on long-term blood thinner, however. Another in many older patients or for whom really we've tried everything, sometimes the best treatment is to put a pacemaker in and actually do an ablation of that switching station, the AV node. So we just acknowledge that the patient's going to be in atrial fibrillation, but they can't send 600 beats per minute down, and we have control then of the heart rate with the pacemaker. So as you can see with the variety of different treatments, often which are done in a very kind of strategic and stepwise manner for that individual patient, depending on their risk factors, their other heart disease, the symptoms that they're having. But we have a lot of different options, but ultimately the goal is an asymptomatic patient with a very low risk of stroke or heart failure.